newer treatments in recurrent C. diff disease. So it's going to be kind of a dual presentation. I'll start us off and talking a little bit about FMT. I'll be starting about FMT, and then my colleague will take over in the end to talk a little bit more about vancomycin tapers. So starting off with the FMT updates. So current in our treatment of C. diff, we currently you have your index episode, and your disease kind of usually manifests with like you treat the disease and it goes away and you're good. But a lot of time that's not the case. A lot of time with C. diff, you actually see recurrence disease, and so you just kind of go in this endless cycle of getting new treatments, and new different courses of antibiotics, different durations. And there's no real great way to eradicate C. diff. Oftentimes, you're always just going to be colonized with it. It's possible to lose that colonization once you get it, but most of the time, our patients are usually going to be colonized for a long time, and a lot of those times it's going to represent in disease, especially an infection of C. diff. So kind of what we have with that, I kind of mentioned so there's some different like treatment options other than antibiotics. Currently in the guidelines for recurrent cases, you can see some tapered vancomycin being used, as well as fidaxomicin. In some cases, there's some literature to support that. But there's a little bit of lack of data currently for tapers of vancomycin or these alternative strategies for antibiotic dosing for first episodes. That's actually what Sarah's going to talk about in her section, so I'm not going to talk too much about that. But when our antibiotics do fail, like what do we do? And that's kind of where FMD comes into play, or fecal microbiota transplant. So for people who are unfamiliar with FMT, essentially it is replacing your healthy stool, or sorry, your infected stool in your colon with a healthy stool. So patients with C. diff, there's also some data out there for ulcerative colitis and some other gastrointestinal diseases. But for this purpose of this presentation, we'll be focusing on C. diff. So this patient has infection due to C. diff, so their gut flora in their colon is kind of have this overgrowth of C. diff. And it's kind of manifesting in a disease. So essentially, they had failed to respond to antibiotics, and then the provider wants to go with the FMT. So what this looks like is we're not taking out the colon, where like a typical transplant you'd think of is like removing of the organ, replacing it with a new one. We're actually going to replace the inner microbiota flora. So above here, we have some like very pristine poop taken from highly screened donors. And essentially, this is very pristine. So this C. diff has been screened. These patients who have or the donors have been clinically screened from like past medical history, social history, a clinical assessment, also like direct stool screening for other pathogens, including C. diff, because we don't want to like give C. diff to the patient who already has C. diff. So essentially, what's going to happen here is endoscopically, or there's some other routes that can be used. We're going to actually place the stool into the infected colon, and essentially in the end we're going to end up with a happy colon that has like now healthy tissue, or sorry, healthy microbiota flora, and ideally without any C. diff. So there's kind of two different arms to think about when treating C. diff with FMT. There's prevention of recurrent C. diff, as well as treatment of severe inflammatory disease. This kind of comes into point a little bit later when we talk about kind of like what are treatment options out there in the US. But essentially for prevention, this is usually going to be followed by a standard course of antibiotics. So you get C. diff, you're treated with antibiotics, and then you get the FMT as like to prevent future episodes. So it's not the treatment itself, it's after you've completed treatment with antibiotics. Usually these patients are very stable. Conversely, for treatment of severe fulminant disease, this is a little bit different. And this is kind of in patients who have a very severe disease. These patients are most commonly in the ICU, requiring pressors. They're having a very poor clinical status, and they're just not responding to antibiotics. So essentially, in the worst case scenarios of C. diff, they kind of result in colectomies, where they'll actually have to like surgically take out your colon. That's kind of just how you get rid of the C. diff if you don't have a colon. That's not ideal. So we don't want to do that if we don't have to. So for these patients that are failing to respond, sometimes in these critical populations, we'll actually do FMT for the treatment. So it's kind of to supplement antibiotic treatment. Typically, we'll treat with antibiotics. If they're not responding, we'll consider FMT, and we'll do courses of FMT and then continue antibiotics for some time being until they're clinically stable. And then you'll end up with another FMT episode once the antibiotics are all done. These are our currently 3 available therapies in the United States for FMT products. So VOWST, this is going to be a rectal suspension. VOWST is going to be in oral capsules. Reviota is going to be a rectal suspension. Then there's conventional FMT, as is reported in the literature. And this is used through a company called OpenBiome. Now, OpenBiome isn't an FDA-approved therapy, but it is the oldest therapy that has been in use in the United States. It's actually it actually comes from what's called a stool bank. And it's not FDA approved, and I'll talk a little bit more about on that in a future slide. But the only two products in the USA that are FDA approved for the prevention of recurrent C. diff is going to be VOWST and Reviota. So this is just a little timeline of CDI treatment. We're kind of starting with like 2010 with the IDSA SHEA guidelines. There was a position paper in the 90s that kind of recommended some therapies before then, but to focus more on just the FMT products, we're just going to start with like 2010. So OpenBiome, as I mentioned, was the first one about in 2012. Now, there had been cases of FMT prior to this. So I think the first actual case, not using OpenBiome, but I think the actual first reported case using something similar to FMT was in the 50s, but in the early 2000s, late 90s, FMT was kind of picking up. And then 2012, this organization kind of formed and kind of spearheaded some donor screening processes, stool manufacturing, and it kind of served as like the principal outlet to receive stool products for the use of treatment of severe fulminant C. diff or just the prevention of C. diff in these patients. So there was no guideline recommendations really for this in these previous guidelines, but once you get into the 2017 guidelines, you actually get some formal recommendations, as well as the 2021 IDSA and ACG updated guidelines. They kind of started recommending FMT for a few more patients. Used to just be considerations, but now they got formal recommendations. And with that, when we get the Reviota and VOWST FDA approvals in 2022 and 2023, these IDSA and ACG recommendations kind of lacked a little bit of clarity, because when they made those recommendations in the 2021 guidelines, they were kind of referencing conventional FMT, aka OpenBiome, because these FDA-approved products did not exist. So we kind of just were in this limbo of like, what do we do with Reviota and VOWST, because they're not technically recommended by these guidelines. So as a result, the AGA, the American Gastroenterological, the AGA, in 2024, recommended or provided some recommendations for using these newer FDA-approved therapies. And I mentioned the stool banks earlier. These are actually not just limited to the USA. These are the list of stool banks I could find in the across the global setting. So OpenBiome is going to be predominantly what we use today. There might be some smaller ones in the USA that are used for C. diff, but I could not find them. It predominantly, if you're trying to use conventional FMT, it's usually going to be sourced from OpenBiome. But as you can see, there's plenty of other sites around the world, but these stool banks, they kind of just spearhead the manufacturing and screening processes of these human stool products. And to talk a little bit more about conventional FMT, they're individually responsible for this. As I said, they're not FDA approved, but they are regulated a little bit by the FDA. In order to do this and to use like human stool for the management or clinical use in C. diff or any other disease state for that matter, you do have to get an IND with the FDA. And that's kind of just providing some bit of oversight. Historically, you didn't have to have an IND, but it was recommended. But I think they actually overturned that, and now they're forcing anyone who wants to use human stool. They're wanting an IND with the FDA for pharmacovigilance and just to have some accountability. With conventional FMT, it's got the most versatile routes. I mentioned like endoscopically in that example, but you could do this orally through a rectal enema, as well as like upper and lower GI delivery. Whereas our VOWST and Reviota, they're really going to be limited just to how they're manufactured, where VOWST is only capsules and Reviota is only a rectal suspension. So with a conventional FMT, you have a little bit more versatility in terms of like how you want to deliver the drugs. Generally, endoscopic is preferred. Under certain disease states, such as like severe fulminant treatment disease, you want to do endoscopic. You want to avoid the oral or enema. And similarly, it has a little bit more versatile use. So we can use this for prevention of recurrent C. diff and treatment of severe fulminant disease, whereas our VOWST and our Reviota products will actually be limited just to prevention of recurrent C. diff. And as I mentioned, these two are the only ones that are FDA approved. That doesn't mean we can't use conventional FMT. A lot of sites still use conventional FMT, namely because it has a lot of like historical literature for severe treatment of the treatment of severe and fulminant C. diff, whereas these two products, there's no data on those at all. They are only studied for the prevention of recurrent C. diff, and that's why they have the FDA label limited to just that indication. In terms of safety of these guys, because you're thinking FMT, you're kind of instilling another person's poop product into your own. So you'd think there'd be a little like, pause and kind of like assess the safety parameters of this, but it's actually generally safe. Now I mentioned it's not like a traditional transplant where they're, cutting into you, where there's expected to be lots of blood loss. This is an endoscopic procedure. It's pretty well tolerated. It's pretty safe. And most of the adverse events are going to be just general gastroenterological, largely diarrhea, flatulence, but diarrhea comes to be expected, especially in these patients with C. diff, especially with the treatment of severe and fulminant C. diff. They kind of have active disease. So it's hard to assess if that is due to the drug itself, but nonetheless, it's these usually common gastroenterological adverse events or side effects that can manifest. I will say there is a few concerns with the FMT products, namely these organisms listed. So there is some FDA safety alerts that have been announced and have been stated in the guidelines as like a point of concern with these therapies. There's been some isolated / rare events where patients who underwent FMT end up developing these illnesses or problems specifically due to these organisms listed here, which has, I don't know if they actually screen for these organisms now as a result. Some of the screening processes are a little bit proprietary, especially with VOWST and ReBiota. OpenBiome is a little bit more accessible. I believe you can find some of the stuff online. However, maybe some of the minute details may be lacking. But generally, these are isolated events and are not really expected to manifest in every patient who gets it. Really, if you're going to see these, it's going to be a one-off case. And then one lastly, food allergens. So I mentioned these stool samples from FMT products are highly screened. I will say they are not screened for food allergens to our knowledge. So there is a possibility, say, for a patient with a gluten intolerance. They don't typically screen for gluten or any other like food allergen. It's just not part of the process. So there is possibles for some adverse events for patients with celiac, for example, that may get like stool FMT that might have a food allergen in it. But other than that, they are highly screened. They kind of mentioned the guidelines earlier. To kind of keep this brief and not just look at a block of text here, this is kind of the best I could do for like summaries of FMT in the old 2021 guidelines by the IDSA and ACG. But essentially, they are using it for both the prevention and treatment. Largely, the IDSA was recommending it for the prevention of RCDI, whereas the ACG kind of went a little bit further and was saying treatment of severe fulminant disease in patients who are refractory to disease. There's some minute details of like when to give it. IDSA was saying you need to, 3 total episodes, whereas the ACG is 2 episodes. And this is both inferring treatment with conventional FMT, as I mentioned, just because 2021 was before both the FDA-approved therapies existed. So in response to that, the 2024 AGA recommendations kind of expand upon this, and they actually recommend all 3 of these agents, so even the conventional FMT, which is not FDA-approved, to be used for prevention of RCDI, as well as for treatment in fulminant disease. And you'll note that the ReBiota and VOWST, as I mentioned, are only for prevention of CDI because that's what their label is for. But one step further, it's actually they limit that therapy in immunocompetent patients. So patients who have any form of immunocompromising condition, mainly mild or moderately immunocompromising, and FMT is being considered, they actually are going to preferentially recommend conventional FMT. And then for any severely immunocompromised patients, they're actually going to recommend against FMT just because of the lack of data. Now with conventional FMT, there's a little bit more data out there that's been published for the immunocompromised population, except for like severely immunocompromised patients. So that's kind of where this recommendation comes from. It's just lack of information for these new FDA-approved therapies in that subpopulation. They do go a little bit more into some more specifics, but I'll try to touch on them in an upcoming slide. But there's a lot of just minute things that come up in the guideline that kind of just need to be assessed on a patient by patient basis. And I kind of mentioned there was a little bit of a contrast between the AGA recommendations for the FDA-approved therapies and conventional FMT. And one of these things is the large doses that conventional FMT carries. So when you're doing FMT for like the treatment of severe fulminant disease, The doses are actually going to be upwards of maybe like 50 grams of human stool. And they're actually going to be repeated, usually for treatment. Like you do one FMT, then you keep doing it until it resolves. And then you have one final FMT procedure outpatient once they're all better. This is in stark difference between the prevention of RCDI. So something who's, someone who's completed standard of care antibiotics and they're just getting the FMT to prevent it again in the future. It's usually going to be like 1 gram or so of stool. So Rebiota and Vals, they don't actually have like a huge stool mass that comes with it. So like the actual relative dose required to use it for the treatment of severe fulminant disease is very small. So that's kind of one of the reasons why the AGA recommended against these two therapies. Similarly, they just don't have data in that disease state, but also just from a more like factual, like mass by mass comparative analysis of, or comparative piece on those two products. Similar, I mentioned the multiple FMTs are needed for treatment of severe fulminant. And then there's actually, they mentioned in their guidelines, a financial benefit of donors for Rebiota and Vals compared to conventional FMT. I actually didn't understand this one completely because conventional FMT, especially open biome, the donors for that are actually compensated. Anyone can go and apply to be a donor for either one of these 3 therapies, and they are all going to be financially compensated. And I kind of looked a little bit pretty deep, and they're all pretty similar. I think maybe the Rebiota and Vals might be like a small amount of money more, but nothing to like make it that big of a difference. So I kind of had a question mark on this one as one of their concerns. Just part of your screening process, you're going to get compensated regardless if you're going to be a stool donor. The extent might be a little different, but I don't think it's of significant value. Some other considerations with FMT, I mentioned immunocompromised. If you're highly immunocompromised, probably not the best idea to use FMT. Similarly, comorbidities and high risk for recurrence. So they kind of mentioned this in the guidelines. Used to be that if you just had 2 or 3 episodes of C.diff, you kind of put yourself in the bucket of consideration for FMT. With the new 2024 guidelines by the AGA, they're actually trying to consider FMT after your first episode if you have sufficient comorbidities or risk for recurrence. They don't specifically outline this, but they kind of just put it in plain text to consider it after your first episode, which is kind of new. Also, patients that may not be the best candidates for FMT are going to be people who are anticipated to get antibiotics in the future. Not C. diff antibiotics, but more so antibiotics for other infections. So, if you're anticipating to get broad spectrum antibiotics, that's a big risk factor for C. diff. So if you get an FMT and get exposed to a bunch of courses of, say, cefepime or other broad spectrum antibiotics, that's going to increase risk for developing C. diff in the future. So if you got the FMT, you're in theory like don't have C. diff anymore in your gut, but you can easily select that out and kind of get refractory C. diff, or sorry, a recurrent C. diff post FMT that can be largely attributable to antibiotics. So patients who have lots of healthcare exposure, maybe have like chronic wounds or osteomyelitis that are going to go off and on therapies of antibiotics, it may not be the best choice for them, but it's something to consider. I mentioned also previous episode severity of C. diff. If you have a really bad case of C. diff, that kind of like pushes you towards like possibly considering FMT a little bit sooner rather than later, as well as refractory, as I mentioned, for like treatment of severe fulminant. And then lastly, bowel perforation or obstruction. Generally, we're not going to do FMT in patients who have severe C. diff or patients that have like bowel perforations or obstructions, just for a safety perspective. And then kind of what to expect post-FMT. I alluded to this momentarily, or a moment ago. But you want to avoid unnecessary antibiotic use just because each dose of antibiotics is going to increase your risk of developing C. diff again in the future. And not all antibiotics are created equal. So certain antibiotics listed here are actually going to be a little bit more risky for developing C. diff in the future. So if antibiotics are needed, you should really make sure that your provider is giving you a guideline appropriate therapy, and ideally something that's going to be more narrow spectrum to reduce the potential risk for C. diff. And we do actually have a KSIC Pearl on this topic, so I recommend you guys going to KSIC Pearl, or sorry, the kymdro.org website, which is the KSIC website, and looking at the clinical Pearl section and finding the C. diff antibiotic risk Pearl. It kind of goes a little bit more detail in this one-page document, and it's super helpful. Also, other post-FMT considerations is safety reporting. So I mentioned those FDA safety alerts. So if something like that were to come up, they should be reported to the manufacturer and the FDA. And I mentioned a little bit ago recurrent disease following FMT. Even without antibiotics, you can definitely have recurrent disease or recurrent C. diff after FMT, whether that's because FMT failed or you just ended up getting it down the road. A lot of times they'll just redo the FMT, especially if it's like early on, within like 8 weeks or so of the initial FMT, they might just redo it. And with that, I'll kind of transition over to Sarah.
Okay, so shifting gears slightly, I'm going to be talking about vancomycin tapers for a first episode of C. difficile. So as Jamison alluded to, this is actually not part of the guidelines. This is not recommended currently. And the question that might come to mind would be, well, why not? And the first answer is we just haven't really studied it. And that's not a clinical trial that's been ongoing at this point. So we just don't really have a ton of data surrounding this idea. But as Jamison already so nicely outlined, recurrence is a huge problem when it comes to C. diff. And what we see is with standard courses of oral vancomycin, our recurrence rates are probably somewhere between 20 and 35%. So that's a significant disease burden. And we just talked about those patients who are high risk for recurrence are going to be anybody who's elderly, who has severe disease, who's immunocompromised, and who is getting antibiotics. And when we think about who our patients are in the hospital, they often have probably all 4 of those risk factors a significant period of the time. So what we did here at Norton Healthcare a couple of years ago was actually started recommending tapered vancomycin for patients as part of a first episode if we thought that they were high risk for recurrence. So those key factors being age, so if they were over 65, if they were immunocompromised, or if they had severe disease. So even in that first episode. And part of the way that we were actually able to do this was we did have a transitions of care program. We were making sure that patients could get their oral vanc before they left the hospital and really facilitating this. Now, what you might be thinking is, why weren't we doing this with fidaxomicin? Unfortunately, fidaxomicin, even though it does have lower risk of recurrence with first episodes of C. difficile, there is a significant financial burden to most patients. That company that makes fidaxomicin does have like a patient assistance program, but it's only available to privately insured patients. So that really knocks out a huge portion of our patient population. And fidaxomicin, even though now it is generic, is still not covered first line by most insurances. And until that catches up, we just really, for the most part, are unable often to have patients fill it because it's just such an expensive medication. We're typically talking a couple $1,000s for the 10-day course of therapy. So that's where tapered vancomycin, maybe just has this role because it's a more readily available medication relative to fidaxomicin, or maybe even to some of these FMT products. So that's just kind of setting it up. Like I said, this was a retrospective matched cohort study in patients with first episodes of C. difficile. So we compared standard vanc 10 to 14 days versus a standardized 12-week taper. Our primary outcome was recurrence of C. difficile within 6 months of hospital discharge. And then the secondary outcomes were a time to recurrence, all-cause mortality within that same time frame, and time to mortality. And the reason that we picked that relatively long 6-month follow-up is we do see that the risk of C. diff remains relatively high through that entire period of time. And we thought that it would also be a little bit maybe unfair to just look, say, 3 months post-hospital discharge when one arm would be on tapered vancomycin essentially that entire time. So we were trying to, give the patients a significant period of time off vanc to really make sure that we actually are going to capture any of those recurrences. I did mention the matching. There were 2 components we matched patients on. So that was age less than or greater than or equal to 65, and then any receipt of non-C. difficile antibiotics. Okay, so on the next slide, we've got our inclusion criteria, which was, of course, just positive C. difficile testing and then receipt of oral vancomycin. We did exclude anyone with a prior C. difficile test within 1 year prior to inclusion. So again, we're trying to really capture first episodes. If they changed their C. diff therapy prior to the planned stop date, so trying to make sure we actually got the therapy that we're trying to test. History of colectomy, and then death or discharge to hospice during that index hospitalization. Because again, we wanted to ensure that these patients actually completed the therapy prescribed. And then I already kind of went over our matching components. So just a couple things to highlight as far as the baseline between the 2 groups. We had 75 patients in each arm. Median age was 72 years. Median CARD score, which is a marker of severity of C. diff and risk of death during that index hospitalization, was similar between those 2 groups. So we would expect that they were about the same level of illness, same thing based on disease severity from the IDSA. One of the key differences, though, at baseline is that we saw that immunocompromised patients were more common in that tapered group. But again, that's exactly what we would expect. We were trying to treat these patients a little bit more aggressively, partially in fact because they were immunocompromised. So that's just one thing to kind of keep in mind. So on the next slide, we've got our recurrence. So this was our primary outcome. So what you see is that in our taper arm in that blue bar, our recurrence rate at 6 months post-hospital discharge was 5.3% compared to 28% in that standard of therapy arm. This was statistically significant. So this, looks like it could be a promising thing. But hold the phone for the next slide. What we see is that all-cause mortality at 6 months was quite a bit higher in the tapered group, 20% versus the standard therapy. And this, again, was also statistically significant. And we can kind of go ahead and talk on the next slide about why that might actually be. So these are just our secondary outcomes. If we look at median days to recurrence, we've got 115 days in the taper arm versus 20 days in the standard therapy arm. So what we see is that those recurrences are happening a lot later. So after we've probably stopped oral vancomycin in that taper arm, relative to obviously happened a little bit earlier with our standard of care. Our median days to death is very similar between groups. And what you'll notice when we look at that taper arm is people were dying a lot sooner than they were having recurrences. So if we go ahead and look at death or recurrence rates, so one or the other, we see that these are actually similar between the groups. This wasn't statistically significant, 22.7% versus 30.8% in the standard arm. So what that tells us is perhaps in our taper arm, patients just didn't have enough time to actually have those recurrences. So that's a huge confounder when we're actually interpreting this data. So even though the recurrence rates do look really good with this taper arm, we do have to keep in mind that it might just be, we selected out that more immunocompromised patient population. Those patients passed away before they actually could have a recurrence. So that's something just, again, is going to be a limitation of this data. So in conclusion, is tapered vancomycin appropriate for first episodes of C. difficile? Maybe. When we talk about this, we really do see from at least the study we've done here, a lot more data is probably needed. And the good news is there is an ongoing randomized controlled trial. That trial is looking at 4-week tapers of vancomycin, which is a little bit shorter than the 12-week tapers that we did in our study. But definitely, I am certainly eager to see those results and see if they're able to maybe tell us a little bit more since they're actually following the patients prospectively. All right, and with that, these are our references. And if anybody has questions for Jamison or myself, we are happy to take those at this time.
If you have any questions, please feel free to unmute yourself and ask. I did have one question. What has been reviewed or I guess researched around the use of prophylactic PO bank in the setting of prevention of recurrence? So I know I'm going to be on antibiotics again. I've had C.diff before. Put me on PO bank with my antibiotics and see what happens.
So that's a great question, Julia. Unfortunately, there's probably not a simple answer of like what exactly is the right thing to do. I will say that clinically, like as a group of infectious disease pharmacists here at Norton, we have bought into this idea of secondary prophylaxis. So patients who have previously had C. diff, who are on especially broad spectrum antibiotics, or we expect they're going to be on a long course, we do often recommend to go ahead and give prophylactic oral vancomycin. Now, the providers don't agree with us 100% of the time on that. So it's not that we do it in every single patient or that even truly we do it in a really controlled or standardized way. But it is something that amongst our group of infectious disease pharmacists, we do think that probably the benefit outweighs the risks. Oral vancomycin minus sometimes kind of tasting bad or causing maybe a little bit of GI upset is a remarkably safe medication because it's not systemically absorbed. So from a safety standpoint, we don't really think that oral vanc is much of a problem, especially when we put it up against the risks of having recurrent C. difficile.
Interesting. Any other questions? All right. Well, as always, thank you all very much for a fantastic presentation. It's always interesting to me to see the progression that we go through with the treatment of C. diff. So fascinating that we're talking about transplant after the first occurrence as opposed to last ditch effort to treat someone. So be interested to see where this goes. So thank you very much. And I hope everyone has a great day. And yes, the title is well done. So have a great one. Thank you.
Thank you.